Initially, I will talk background. Regarding IL-2, similar select trial in patients with MRCC was reported by Dr. McDermott, who talks later. Retrospective analysis suggested that clinical characteristics and tumor features such as UCLA SANI score, clear cell histology, and CA9 could predict for IL-2 benefit. The study was conducted to prospectively confirm the above predictive models or factors. What is UCLA SANI score? Survival after nephrectomy and immunotherapy. And factors that predict survival and response to IL-2 were regional lymph node status, symptoms, location of mets, sarcomatoid histology, TSH level. Results: neither clear cell histology nor staining for CA9 could predict for response to IL-2. Only UCL SANI score may identify patients who are unlikely to respond to IL-2. Results of IL-2 select trial were not satisfactory, demonstrating that it is difficult to prospectively prove the result of retrospective study. How about interferon-alpha? In Japan, we urologists still use interferon-alpha, especially for lung mets only patient, probably due to this result. This is overall survival of more than 1,400 patients with MRCC at the cytokine era. 5-year OS rate was 23%, excellent result. In addition, in our retrospective study, we reported association of SNPs of RS 4796-7993 that located upstream of STAT3 gene with interferon-alpha response. In patients with CC genotype, 8 patients out of 10 were responder, whereas in GG patient, 4 patients out of 22 were responders. That was statistically significant, and odds ratio was 8.38. If we would use CC genotype of RS 4796-793 as a predictive marker of response to interferon-alpha, on the assumption that response rate of interferon-alpha is 15%, positive predictive value is 52.8% and negative is 88.2%. In addition, in our retrospective study, we showed 23 SNPs showed significant association with interferon-alpha response. Among them, we select 11 SNPs and perform this study. The objective of our study is to confirm the correlation between the anti-tumor effect of interferon-alpha and 11 SNPs of STAT3-2, STAT3-0, SOX3-1, etc. Japan Immunotherapy SNP Study Group for Kidney Cancer conducted this RCC select trial. Patients with MRCC who have measurable target lesions were enrolled, and blood sampling was done, and DNA extraction was done by clinical laboratory company. 5 minutes union of natural interferon-alpha were administered 3 times a week and assessed the tumor burden every 12 weeks. Data correction and links SNPs data with clinical data, and we did statistical analysis. Inclusion criteria was an average one, and in patient characteristic, around 90% patients have PS0, and all patients received prior nephrectomy, and more than 90% patients have clear cell histology. And the most characteristic feature was site of metastasis. Around 70% patients have lung mets only. Probably because many doctors consider interferon is especially effective for lung mets. Totally, 211 patients were enrolled and 203 patients were eligible for ITT analysis. Response rate was 13.8%. That was reasonable, and CR rate of 4.4% was more than we expected. And 180 patients were eligible to analyze correlation between SNPs and clinical benefit because our protocol defined at least 12 weeks of interferon alpha treatment was indispensable for analysis correlation between SNPs and clinical benefits. At first, we defined SD as those without clinical benefits. The comparison was CR/PR versus SD/PD. However, none of the 11 SNPs examined was statistically significant. We next defined SD as those with clinical benefit. The comparison was CR/PR SD versus PD. However, again, none of the 11 SNPs examined was statistically significant, but SNPs of STAT32 in SNPs of STAT32, p-value improved. So we next define the case as long-term SD if duration of SD is greater than 24 weeks. This method was used in phase 3 trial of temsirolimus reported in New England Journal. So in this case, cases of SD without record of assessment at the time of point between 20 and 28 weeks were excluded from analysis. However, if who had SD at the first assessment at 12 weeks and became PD before 20 weeks is short-term SD, and if SD and had recorded at second or subsequent assessment later than 20 weeks is long-term SD. So for this reason, 70 cases of SD were excluded from analysis. This is correlation between clinical benefit and PFS. Median PFS of modified clinical benefit using CR/PR plus long SD was clearly longer than that of conventional clinical benefit using CR/PR plus SD, demonstrating that modified clinical benefit can be a better surrogate for PFS. And the comparison this time is CR/PR long SD versus short SD/PD. And in SNPs of STAT32, that was primary endpoint of our study, that was statistically significantly correlated with response to interferon alpha. Namely, in patients with CC genotype, around half patients were effective, and that was almost twice as that of in patients with TT genotype. Our result is response to interferon alpha was not associated with any of the 11 SNPs examined. However, when we assess a patient with CR/PR and long-time SD as those with clinical benefit, and we evaluated the correlation, the significant association between STAT32 and clinical benefit of interferon alpha was observed. CC genotype of STAT32 was significantly associated with clinical benefits of interferon alpha. And this is the schema of interferon alpha signaling. STAT1 and STAT2 is phosphorylated in the receptor of interferon alpha and move into nucleus and works as a transcriptional factor and resulting in the overexpression of interferon alpha related gene. On the other hand, STAT3 located downstream of IL-6 receptor, and when phosphorylated, it moves into the nucleus and also works as a transcriptional factor and resulting in the overexpression of SOX. And SOX inhibit interferon alpha signaling. We think that is one of the reasons why STAT3 polymorphism is correlated with interferon alpha response. And this is prognostic and predictive biomarker in other solid tumor. In breast cancer, HER2/neu is a worse prognostic factor, whereas it is a predictive marker of response to trastuzumab. And c-KIT in GI stromal tumor is also a worse prognostic factor, but it's a predictive marker of response to imatinib. And ERCC1 in non-small cell lung cancer is similar. In MRCC treatment, there exist prognostic markers such as MSKCC criteria. So far, there have been seldom predictive marker reported. Also, Dr. Atkins yesterday showed excellent result of SNPs of molecular targeted drugs. Now, 2 cytokine and 4 molecular targeted drugs are available in Japan. When we use cytokine or molecular targeted drug, which order is good? Which combination is good? We have only limited information. Identification of a predictive marker for response to interferon-alpha is a first step for personalized medicine in MRCC treatment. We believe this is the first prospective study demonstrating that STAT3 polymorphism can be a predictive marker in the treatment of interferon-alpha for patients with MRCC. Thank you for your attention.